Good morning. Thanks very much for the invitation. Thank you to Sally for inviting me. Things to check if you're invited to talk. Find out how long your talk's supposed to be for. Don't read the programme and find out the words keynote in an hour or after your name, which is slightly worrying. It's great to be back in Nottingham. As I said, I was a trainee here, and I can reassure you, it looks like there's a lot of trainees in the room, that you're in one, if not the best, school of anaesthesia in the country. And your opportunities from here are limitless. Just to give you an idea of that, it wasn't that long ago I was sat where you were, and now I've managed to get up here. But it takes me back to when I was just out of my supernumerary period in Nottingham. And I was assigned to a list with Alan Aitkenhead, who, as many of you will know, was the professor of anaesthesia here for many years. I hadn't done the professorial list before, so we do what we all do when we're sent to an unfamiliar list. We ask the ODA what to do. What were the do's and don'ts of the professorial list? Thankfully, good ODA, full of top tips. Never ever take the monitoring off before the patient's extubated because the anaesthetic's not over. Got it. And Prof always asked for trainees about 5-pentone. That was a quick win. Straight to the coffee room, learned the PKA, learned how to draw it, knew what the pH was, bosh, job done. This is going to be a good day out. It was therefore somewhat disappointing when halfway through the list, Prof turned to me and said, "So tell me how this vaporizer works." He obviously noticed that I appeared to have had some sort of small stroke because I couldn't speak. And he very kindly offered to give me a clue, which I gratefully accepted. He said, "It's all to do with saturated vapor pressure." I didn't know what any of those words meant. But the silence was weighing heavy, and I felt I had to give an answer, and he was looking slightly impatient. In retrospect, I wish I'd gone with silence, because my answer of more asleep, less asleep, was very much not what he was looking for. He immediately had to excuse himself to go for one of his long walks for fresh air and never came back to the list. So it was slightly ironic that 15 years later I was invited to join the editorial board to produce the 7th edition of his revised textbook. So you can come back from very inauspicious starts. As I said, I now work in Sheffield. My major interests are neuroanaesthesia, neurocritical care. I'm also lead for the Major Trauma Consultant Service, and I fill that role once a week. What am I going to try and teach you today? Well, the first is to give an overview of 21st century major trauma centre management and try to give you a flavour of what we're doing currently within there. It's a very dynamic specialty. Guidelines and practice change rapidly, so I'll try to give you an update of where you're at. The second thing I'm going to teach you is a little bit about 16th century art history relating to rhinoceri or rhinoceroses. And finally, I'm going to try instill in you a great cynicism. I want to show that fake news is not a 21st century phenomenon, and it's been around for some time, and it's very important you're able to recognise it. It appears particularly pertinent in an election week. Some of you may be aware of Ross Fisher. He's a paediatric surgeon who works in Sheffield. He's big on presenting. He goes around the world teaching people how to present. As a result, PowerPoint is virtually banned in Sheffield. You're not allowed bullet points. You're not allowed cut and paste graphs. You're not allowed to put red boxes around data in tables. So I haven't done any of that to keep Ross happy. What I have done is prepared a summary document. So it's got all the links for all the references, the papers I'm going to talk about, some more traditional PowerPoint type slides for you, maybe of some use in revision. And that's available at my blog. So if you go to STH Journal Club, that's in Sheffield Teaching Hospitals, it's the first hit on Google. And I've also tweeted a link to that as well. So, as I said, I'm from Sheffield. It's not, as you might imagine, full of William Blake's dark satanic mills. And part of a prerequisite for gaining study leave is I have to try and sell it a bit because we have consultant jobs available for those of you who are starting to come to that market. Modern, vibrant city, 2 hours away from London, and more importantly, 10 minutes away from the Peak District. What's even better is when you haven't got an HDU bed, this is my ODA, this is where you can go when you feel really sad that you can't do your afternoon case and have fun. So it's a great place to live and I'd recommend it. My only conflict of interest is that I'm on the editorial board of the Friendly White Journal. We are friendly, we are nice, please send your work to us. And this is a brief plug for our forthcoming supplement. This is Advances in Perioperative Care. It's the first time we've done a joint supplement with the Royal College of Surgeons. and it will also be co-published in the BJS. As you might imagine, the anaesthetist did most of the work, and the surgeons were just there for the middle bit. This will be released free, open access, at the start of the WSM in early January, so keep an eye out for it. A brief warning. As I said, I'm going to try to talk to you about contemporary cutting-edge management. What I don't know is whether this has made the exam answers that the examiners have when they sit in front of you. So anything I'm going to tell you today, please use with great caution when you visit Red Lion Square. The examiners might not be able to handle the truth because it's not on the thing in front of them. But it's important that you're aware of what we're doing at the moment in clinical centres. If you arrive in a trauma room in an MTC with your hands like this, saying, I'm going to manage this according to ACLS principles, you will be laughed out of the resus room. So just bear that in mind. Okay, why is this important? A lot of anaesthesia is art. If you think about a case you commonly undertake, for example, an appendicectomy, think how much of your practice is based upon level 1 evidence. How much of what you do day to day is from RCTs, carefully analysed stuff that's been randomised? Or have you learned a lot of practice and a bit of art when you go? It's probably a bit of both. What's important, though, is to avoid creating dogma and shrine principles, and it's good to challenge things. Anaesthesia is prone to introducing pseudo-axioms. What are pseudo-axioms? These are false beliefs that are passed on from generation to generation of anaesthetic providers, often without any challenge or real analysis. How do you recognise these? Well, one clue is when the person telling you this says, you must always or you must never. Because very rarely is that true in medicine. And it's very important that you're able to recognise these things. However, this isn't a new phenomenon. So this is Jura's rhinoceros. The first rhinoceros came over from India to Portugal in the 16th century, and there was a great rush to be part of this, because this was good times. This was crazy. Everyone wanted to ride this pony and make some money out of it. So Jura was a very famous Austrian woodcut artist. If, in between Viva times, when you're at the Royal College of Anaesthetists, you still visit the British Museum, if you go down to the print sections, this is available for you to review in the print section. And it might impress someone when you can recognise it one day. Jura, like many of the neurosurgeons I work with, didn't let the small fact that he'd never seen one hold him back in having a go about doing something about it. So what he did was he spoke to a man who'd seen it. And he actually did a pretty good job. Now, the man described it as looking a bit like a tortoise, which, when you've seen a lot around it, you sort of get, but he took that to mean that it was covered in armour, so he added a shell all the way over. He also took a little bit of artistic licence and added, right at the top, a second horn for a bit of, pimped it up a bit. He pimped up his rhino. Why is this important? Well, at exactly the same time, another artist called Bergmeyer also did this, but he'd actually seen the rhinoceros, and he actually argued he did a pretty good job. That's what a rhinoceros looks like. However, Jura was a big name in the art world. He had influence, so everyone believed him, and his woodcut went viral and went all over Europe. Why does that matter? Because for the next 250 years, every single picture of a rhinoceros copied Jura's. They've all got armour, they've all got the extra horn. And it was only in 1750, when Clara the rhinoceros came to London, that people realised he got it wrong. So now, if you only learn one thing, and it's maybe the only thing you learn today, you can now date pictures of a rhinoceros. So if it's got a third horn, it's somewhere between 1515 and 1750. But we wouldn't do that. We're clinicians, we're scientists. We wouldn't let one loud voice of a respected body alter our practice forever, would we? I think we probably did. So in 1977, James Steiner crashed his plane near Hebron, Nebraska. His wife died at the scene, and it's fair to say he was somewhat disappointed with the care he received. And this is a quote assigned to him that's now often been repeated. Within 2 years, he piloted the first ATLS course in Nebraska, and by 1980, this had been accepted by the American College of Surgeons and rolled out internationally the same year. By 2014, 1.5 million people had sat the course in over 60 countries. And every year, 3,000 courses are run, training about 50,000 clinicians a year according to ATLS principles. Now, I think an ATLS course is somewhere between £600 to £800. That's an annual turnover on ATLS alone of £40 million. So this is not just a training course, this is actually a huge corporate machine. Now, I'm not saying these two facts are related, but the picture on the left is where the American College of Surgeons used to live. And in 2003, it's fair to say they upgraded somewhat. I think ATLS is very much the juror of what we've done. We accepted these principles, we never really challenged them, and this has perpetuated for many years. And it's only in recent times that people have started to call these into question. Now, Bob Winter, I'm glad he's not here this morning, he gets very upset when I talk about ATLS. People have said ATLS did a very important job. It provided a common trauma language that people can speak. And I think that's largely true. They'll also tell you that it saved lives. Well, the evidence supporting that assertion is far weaker. So for those of you with an educational interest, you'll recognise this as Fitzpatrick's triangle. And this is the scheme work by which we measure and assess the value of training in educational courses. If we think about ATLS in particular, it's only ever really achieved the bottom two levels. The reaction's good. People like it. Most people like going on a course. You see your friends, you have free coffee, you might get a lunch, and it's a lot better than carrying the third on-call bleep at Queen's. You might even learn something. A few facts, maybe a few skills, but in common with nearly all training courses, there's a rapid decay in these skills. And within 6 to 12 months, actually nearly everyone has regressed back to baseline level. Maybe I'm being slightly unfair to ATLS. I'm expecting too much of it. Trauma is a heterogeneous disease. It affects multi-systems, and although it can all come under one label, it's actually very different. We normally accept the definition of polytrauma to be an injury severity score of more than 15, but that can occur in multiple different areas of the body. And I'm sure, as you've all seen, there's a big difference between pelvic trauma compared to abdominal trauma compared to thoracic trauma, and yet they all get lumped in together. And we've seen this in many areas of medicine, and we've learned hard lessons. When I first started working on Queen's ITU in about 2003, about the next 5 years, we always had somewhere between 4 and 6 patients with severe ARDS all the time. They were ever present on the unit. And throughout that period of time, we went through a raft of trials, all looking for a magic bullet or single intervention that was going to make things better. But ARDS is a bit like trauma. It's a completely different disease. If your ARDS comes from pulmonary contusion, you'll behave differently compared to if it's profound aspiration. And as a result, we've had multiple negative studies. Oscillation, prone positioning, steroids, nitric oxide. Nothing made a difference. What did make a difference was doing lots of small things very well. Sedation holds, lung protective ventilation, use of PPIs, proper nutrition. We've also seen similar things in other areas of trauma as well, particularly my area of interest, which is neuro. Traumatic brain injury is learning this hard lesson as well. So if you look at any traumatic brain injury study, this is a terrible catch-all term, again, for a variety of diseases. So we have 6 different conditions here, all of which that will fall under that bracket. We've got a large extradural, of which I would expect mainly it's in young people with no underlying brain parenchymal damage. A subdural hematoma, something that's often associated with parenchymal damage, and usually in the elderly, often with alcohol abuse and often with anticoagulation. Diffuse contusional injury, generalized cerebral edema, diffuse axonal injury at the bottom, or traumatic subarachnoid hemorrhage. It's unrealistic to expect all these disease conditions to behave the same, to have the same outcome, and to respond to the same intervention. So similarly, in the management of trauma, it's unrealistic that one course and one protocol is going to be able to influence outcome from our patients. What you actually need is people who deal with it a lot, experienced individuals who are able to individualise and prepare bespoke care for those patients under their care. So why has ATLS remained so popular, particularly in the US? Remember why it was done. It was done to help rural providers who infrequently met trauma. So people who only dealt with maybe 10 or 15 trauma cases a year in a rural centre. Well, that doesn't exist anymore, does it? Well, it does in America. So the A shows you where James Steiner crashed his plane. And interestingly, in Nebraska, the home of ATLS, there is still no level 1 trauma centre in the whole state. To give you an idea of the scale that we're looking at, that's England superimposed on it. So if James Steiner crashed his plane in the middle of England, he would have 7 to 8 trauma centres closer than he would in the US. So within the US, once you get away from the coasts, you do meet very inexperienced providers who meet trauma infrequently, and there may be some value for them. That's not what's happened in the UK. We've moved to a major trauma model, and we have multiple major trauma centres all providing bespoke care. And it's often very different. If you look at the protocols they use, it's been designed for that hospital and for that population. For example, those that have increasing number of older patients have different protocols there. In London, there's a much higher rate of penetrating trauma, so they have different protocols compared to we have in Sheffield, where 98% of our trauma is blunt. A lot depends on the pre-hospital care arrangements, those that have very advanced HEM services or lots of hospital paramedics in cars, similarly have different situations. In some of the London centres, even doing direct-to-CT admissions. Once you get there, what sort of expertise do you have around the region? So, for example, in Sheffield, we have some phenomenal interventional radiologists who appear to be able to stop bleeding in everything. So we would often take cases that in other centres would go to theatre for a laparotomy, straight to IR. Similarly, other places have had great experience with TEG, using that to guide, whereas in Sheffield, we still rely on predetermined factor-based ratios. So we've managed to produce bespoke care. So why is ATLS still relevant? Well, one of the difficulties we've had is it's also managed to enshrine a lot of dogma. It's created multiple trauma pseudo-axioms that we are struggling to get rid of. Writing textbooks is difficult. As soon as you've written it, you're out of date. And I appreciate that, and that's one of the problems with the course manuals. However, the pace at which they update their manuals is glacial in a dynamic specialty that changes almost year on year. So look at some specific examples. What do we need next? Pencil or a pen. Right. This was a big problem in the 80s. All right? A massive problem. Similarly, trauma was a problem that ATLS hoped to meet. ATLS is a pencil trying to fix a broken MP3 file in your iPod. It's not needed anymore. What does it keep telling us? It tells us there's a triphasic distribution of death after trauma. There's not. A large US study of 4,000 patients, 20% of which had penetrating injury, and a Dutch study of 9,000 patients both showed it's just an exponential decay. Most of the deaths occur at scene and non-survivable, and then there's a long tail associated with it. Similarly, the much beloved of the exam candidate ATLS trauma shock table. This is in most textbooks. I have seen this in the FRCA example answers when I've sat and watched the exams at the college. The 0 to 15, 15 to 30, 30 to 40 shock definition. This doesn't exist as a clinical entity. Data from TARN, the Trauma Audit Research Network, has analysed numerous cases between 1987 and 2007. They looked at every submission they had, worked out their ISS, estimated their injuries, and from there predicted what their level of shock should be. The only positive finding that they managed to discover was that in ATLS type 4 shock, you may get a small increase in heart rate, and you may get a small decrease in systolic blood pressure. That's it. The German trauma database similarly analysed over 33,000 cases and found that 90% of them didn't fit into any of those classifications of shock. The 10% that did were all class 1 shock. Why does this matter? It matters because people then misinterpret the clinical science in front of them. They think the young patient is not shocked. They think they're okay, and they're under-resuscitated, and they lose the speed of management. This is the importance of not creating dangerous rhinoceroses that run around your resus room, causing people harm. What's even worse is not even the instructors believe what they're teaching you. I've sat on a ATLS course and had clinicians I work with say this tomorrow, but if you ever say this to me clinically, I'll punch you in the face. What sort of course is that? They asked 383 ATLS instructors and course directors what they thought about the shock table. Half of them said they'd never use it. They thought it was completely wrong. Only 10% thought it had some value. Why are we making you spend study leave on a course that not even the people teaching it believe in? What else have they done? They still put pictures of diagnostic peritoneal lavage in there. I'm yet to see anybody undertake diagnostic peritoneal lavage. They have added in really useful statements that CT scanners are dangerous places. They came up with the phrase, the donut of death. You must never take your patient to the CT scanner if they're unstable because they'll die, and then we'll all criticise you. They show that picture of the tension pneumothorax in the CT scanner and say, this is a CT that never should be taken. No, it should be taken. It's fine. CT scanning is of immense value in trauma patients, and it's perhaps the unstable patient who does best of all. Who's taken a patient to theatre without going to CT for an expiratory laparotomy for hemodynamic instability? Not many. Was it a rapid process in achieving hemorrhagic control once you got to theatre? No, it's not. You get to theatre quickly, the surgeons open the abdomen, and then they fertile. Pack in, pack out, bit of bowel out, bit of bowel back in again, another pack in, another pack out. 15 minutes later, you're going, he's still bleeding to death. Have you not found it? You could have found the answer within 2 minutes in a CT scan on the way. And this is borne out by published evidence. A recent meta-analysis of 11 studies involving 32,000 patients showed that early CT scanning reduced 24-hour mortality by 20% and 30-day mortality by 30%. This is a huge advantage, and that's why it's a quality care indicator. And that's why it's part of our best practice tariff. So it's not so much the donut of death, but rather the circle of life. Just when I'm talking about best practice tariff, and that was alluded to in the excellent talk before, talking about Neela, before very long, you guys will be the opinion leaders of the country. You will be setting best practice tariff, and it's a very dangerous thing to do, particularly if you rely on poor evidence and pseudo-axioms. Once you say we only get paid by doing something, we have to do it, whether it's of relevance or not. I'll come back to that again in a second, but it's just important to remember that once you add in payment for something, we end up forcing to do things that we don't want to do. And there's one of direct relevance to anaesthesia in terms of tracheal intubation for coma score less than 8. I'll talk about that in a second. This is a quote from Douglas Bader, who was an RAF pilot who lost both his legs in a crash. So I think he knows a thing or two about trauma. And this is right. There are no rules in the management of trauma. You've got to consider the patient in front of you and try to put it all together. There is not one rule that will be able to fix all people in one go. The problem is that we've moved on from rules. We now call rules guidelines. And the general perception is that guidelines are mandatory, particularly if they're preceded by the word nice. People feel they must be done. And yet, if you actually look for a definition of what guidelines are, this is probably the best one. So this is from the US Veterans Association. And it points out that guidelines are there to streamline processes, to make the care you give happen quicker. That's all. They're not meant to be mandatory, and they shouldn't be followed blindly. And that's important. So, I've basically told you everything you've read in all the books is wrong. So now I'll try to give you some updates about some of the contentious areas in trauma that I think represent best practice. We have lots of challenges in trauma, the greatest of which is our ageing population. Now, you guys at the sharp end of managing trauma that comes into the resource room, I would definitely recommend you read the Tarn report, Trauma Care of the Older Patient, as that is essential reading. We have an ageing population, but a population that's still very active. They still drive, they still walk, they still jump out of aeroplanes, so they still get traumatic injuries. More than 50% of submissions to TARN are now aged over 60. And bear in mind, all TARN submissions specifically exclude fractured neck of femur. So neck of femur is on top of these numbers. Older patients tend to have similar injury severity scores on admission. They have similar distributions of injuries, and yet their mortality is much higher. And part of that is because they're undermanaged when they come to hospital. Silver trauma is going to be one of the major challenges facing all acute healthcare centres over the next few years. LD patients tend to be under-triaged. They're less likely to be transferred for tertiary or quaternary care. They wait longer for investigations, and they wait longer for interventions. They're less likely to be met by a trauma team on arrival, and they're less likely to have a trauma pan scan as they go. So part of their increased mortality may be a self-fulfilling prophecy because they're undermanaged. There's also often a general perception that some of this is futile. Because of the effects of comorbidities and other things, they won't do as well. However, that's not borne out by the evidence. Of the patients who survive, the majority very rapidly return to their level of functioning. It's actually much easier for you to return to your level of functioning as an elderly patient with comorbidities. If you live in a nursing home, you will get back to your nursing home existence relatively soon. It's much harder for the young patients to get back to their level of functioning. So it's worth working hard on the silver trauma patients because they are a particularly high-risk group. What else makes them difficult? Well, our helpful physician colleagues love putting them on irreversible antiplatelet agents and irreversible anticoagulants. Who would have thought warfarin was actually not a bad drug in the end? They also fall over a lot. The leading cause of trauma in the UK is now falls from your own height. Not road traffic collisions, it's falling over. And it's often exacerbated by medications as this. A word of advice to you. Once you reach the age of 70, you have to make a decision in your life. You can either choose stairs or alcohol. You can't have both. I am going wine and bungalow all the way. Why else is this relevant? Well, if you go, the London Trauma Conference has been on this week, if you go to events such as that, I guarantee you will learn about rainbow unicorns. And this comes from the military models. The military have done incredible work in the management of major trauma. There is no doubt about it. And a lot of their non-technical and process-driven we have learnt, particularly their CT scanning protocols. Ours is the Bastion protocol that we use. However, we need to think about a population. Their population isn't ageing. I would love to manage hyper-fit 20 to 30-year-olds who run 6 miles a day, who are brought to me in a helicopter staffed by a physician, who have received fresh whole blood at the scene, who arrive in a trauma setup like Bastion that specifically deals in trauma with teams that are given time to train together and that never use the phrase ACLS. Until the army gets sponsored by Greggs, this is not going to be the population that comes to me from Barnsley. So you have to be very careful. So when you see this graph, and this graph shows the improvements in mortality in military conflicts from year on year on year, which is amazing for given injury severity scores, that's fine. But that is a very specific and actually a very small population compared to what you deal with. Okay, some specifics for you guys who are going to be at the sharp end dealing with trauma cases. So you might not recognize these. This is because it's not an emergency medicine conference. These are the ED Dice. They keep these by the phone and they roll them to find out what the Glasgow Coma score is. They keep rolling them until they find a number that will make you come. Notice the top number's 12 because they recognise the fact you're not coming for 13 to 15. Never going to happen. You are busy. Okay, why does this matter? And this is one of those best practice tariff indicators that causes us trouble. The need to have the airway secured if the Glasgow Coma score is less than or equal to 8. Where did that number come from? I have no idea. I've tried to find it. It definitely appears in ATLS, but I can't find the origin or the evidence basis for it. I suspect one of the major reasons is it rhymes. Less than 8, intubate. That'll catch on. Presumably they rejected at some point on the line, more than 9 going to be fine, less than 7 going to heaven. Obviously, the important thing for you guys to remember is that 8 is not a useful number to predict the requirement for tracheal intubation. If I'm late back from cycling, my wife will regularly have a Glasgow Coma score of 8. She will not open her eyes, she makes no sounds, but she appears to move spontaneously. The best guide to tracheal intubation is once you lose 2 points on your motor score, regardless of the total score. Once your motor component is 4 or less, that's the level at which you are highly likely to require airway support and or protection. Also bear in mind that the timing of tracheal intubation has never been shown to alter outcome. So it doesn't matter whether it's done pre-hospitally, on arrival to resus, after the scan, or after the transfer to the tertiary centre. If you decide to put a tube in just in case, you will delay transfer on average by about 1 to 2 hours. And that means they don't get definitive care for that period of time. And also, if tracheal intubation is done poorly, stress responses to not-obtunded laryngoscopy, particularly in the context of traumatic brain injury, it actually has the potential to do more harm than good. This is a reminder about necks, and in particular, coming back to the elderly. As I said, most of the young patients will often get a trauma pan scan, so we tend to get necks done with them. The elderly often get more selective imaging. If you are scanning an old person's head, please scan their neck. The rate of neck injury has been relatively static in the UK. Cervical spinal cord injury occurs in about 15 patients per million population, and that figure hasn't really changed. What has changed is the number of patients aged between 51 and 85 having cord injuries. That's gone up hugely. And that's because they have pre-existing cord disease. That means that their spinal cord is already impinged, either by spinal cord stenosis or by disc disease. They're far more likely to have disease, and we've seen a big increase in central cord syndrome cases as a result. So I'll talk a little bit more about tracheal intubation with the cervical spine in a few minutes. Okay, let's do a clinical scenario for you. So, this is a young man. He has done something stupid and he's broken his neck about C5. The spinal surgeons want to do an operation. They're not sure what. They'll figure out when they get there. Very unlikely to bleed. Won't need HDU afterwards. All will be good. The sort of thing spinal surgeons say. Okay, he is going to need intubated. He's going to need intubating. He's starved. His neurology is normal at the moment. Okay, I'll give you a few options. You have to vote, because you have to put a tube in. You can't not do him. You can't hand him over to the afternoon shift. This is your work. Who's going to intubate him with video laryngoscopy? 25%? Who's going to do awake or asleep fibre optic intubation? Do you want? Who's going to use a Mach 3, a strong arm and a bougie? Lots of you are trying to roll this case over and not saying. I know what you're doing. This causes a lot of anxiety. And as you can see, there's a lack of consensus even in the room. Even highly educated, trained people are struggling to come up with a definitive answer. Where can we look for advice? Let's go across the pond to the litigious states. They must know. They undertook a 10-year review looking at 252 patients with neurology who went for spinal fixation. And they reviewed what their clinicians chose. In a place where you'll be sued for making your McDonald's apple pie too hot, this is what they did. So probably a sensible place to go. 50% of the cases they did with video laryngoscopy. 40% they did with fibre optic intubation, either awake or asleep. Only 2% they used the Macintosh blade. So clearly very different practice. What causes all this anxiety? The fear of being blamed for deterioration in neurological function. And we are an easy target because we have manipulated the neck. We get blamed for all sorts of things. You've got to remember several things when it comes to tracheal intubation and cervical spine. The first is that 5% of patients with cervical cord injuries get worse anyway. Even if you don't intubate them, even if you don't operate on them, they get worse due to a combination of cord edema, cord inflammation, actual cord infarction, or worsening hematoma. Okay, that will happen anyway. Often within 24 hours, that's usually when they've had operations from spinal surgeons, but several more will occur 3 to 4 days later, and that's often when they blame the intubation. That's actually usually due to venous thrombosis, which then causes much worse cord edema. If you really want to protect your patient's cord, don't worry about how you intubate them, worry about where they go afterwards, because it's prolonged hypotension in the post-operative period that's probably the biggest determinant of that. The second thing about the whole idea of litigation is it's actually incredibly rare. MacLeod and Calder in 2000 did an excellent review. They searched PubMed for every single mention they could find of neurological deterioration after tracheal intubation. In the whole of PubMed, they found 10 cases. When they looked at those 10 cases, none was actually intubation truly implicated. It had been blamed. One patient had a cardiac arrest for 55 minutes. When they woke up, unsurprisingly, their cord was not great, but the anaesthetist who intubated them at the arrest got blamed for that. Tim Cook did an analysis of the whole of the NHS litigation between 1995 and 2007. There was not a single NHS litigation payout for worsening neurological deterioration after tracheal intubation. If we go to the States and look at their closed claims database, over a 37-year period, only 37 patients successfully received a payout as a result of neurological deterioration after surgery. We'll be slightly cautious with the closed claims database as that doesn't include those cases that were settled outside of court. But still in the whole of the US, 37 patients. Nearly all those patients had a normal cervical spine preoperatively. The major cause is positioning. So if you're worried about your trauma patient, the one I worry about the most is the little old lady or the little old gentleman in the lateral position having their either hemiarthroplasty or total hip replacement done, having fallen. They're the ones with the diseased spine, and they're the ones that could wake up quadriplegic. I worry very little about the young men who are coming in, even with horrific spinal fractures. There are lots of guidelines, though, to upset you. In particular, NICE trauma guidelines are very dogmatic about it. Similarly, the American College of Neurological Surgeons say you must use immobilization, be very careful. And they have a good evidence base for that. They provide no references and instead use the phrase, because we have cumulative experience over many years. That sounds like a rhinoceros to me. Don't worry about intubation. This is what causes the damage. When the person went through that windscreen, that's what damaged their spine. Even on your worst day, even on your most cack-handed, hungover, caffeine-depleted day, you are not going to reproduce those forces. Really. It takes about somewhere between 4,000 and 6,000 newtons of force to fracture cervical vertebrae. Even if you drop the neck when holding it, as I have seen a spinal surgeon do when trying to pin their head in a broken neck, that's only 40 newtons of force. In addition, trauma is a series of repetitive motions. So the amount of energy transmitted is a product of force times time. Laryngoscopy is usually relatively quick. Trauma is an oscillatory wave that actually magnifies and focuses that energy, a focus that you cannot reproduce. Ever. The studies that have looked into this in detail have shown that in animal studies you need 30 minutes of continuous cord compression to cause damage. Again, if I haven't put a tube in within 30 minutes, I probably need to find a new day job pretty rapidly. Also, it's hyperflexion, not extension, that causes the problem. In the normal range of movements, you have amazing things, bones, muscles, ligaments, and discs that absorb most of this energy. So if you take only one thing away today, remember, you are not going to be causing any harm compared to what's already been done. How common is it? You're worrying about an incredibly rare event. So if we take data from the Nexus study in the States, that's got about 35,000 patients, and TARN analysis, that's got over 250,000 patients. Cervical spine fracture with associated cord injury occurs in about 0.9% of cases. In nearly all those cases, the actual spine itself is stable. Those spines that present to you unstable means that all the energy when they went through the windscreen was transmitted immediately to the cord, so the cord damage has already occurred. It is a rare event. Because of our aging population, sciura is out. So this used to be the other thing that we talk about in exams that worry people. Spinal cord injury without radiological abnormality. That's incredibly rare, about 0.09%, but actually, because we scan more people and more elderly people, all our patients have radiological abnormalities. So they've gone for a really catchy new acronym. No, this is what they're running with, SCIURCT, spinal cord injury without CT evidence of trauma. So Older patients have a higher incidence of coexistent disease. So as a rule of thumb, once you go past your 30s, each decade, 30s, 40s, 50s, that's your percentage chance of having asymptomatic disc disease or called canal stenosis, just to cheer you up if you weren't feeling old enough already today. Mechanism is the important thing. I'm going to prove that to you again by showing you where you get spinal cord injury. So as the graph goes up, this shows the higher rates of cervical cord injury after trauma. Okay, Saudi Arabia appears to be incredibly safe. I'm glad it's safe for something. We sit in the middle at the same at Vietnam. We've got about 15 per million population. The US, so that litigious, terrified place where they put a collar on you if you trip over somewhere or fall off your chair, has a rate of 30 per million population. And the reason theirs is much higher isn't because of protection, it's because they drive badly and don't wear seatbelts, so they go through windscreens. If you look further up, it's heavy industry that causes cervical spine injury and lots of mining, so Brazil, South Africa, China, Iran. If a mine falls on you, it doesn't matter what you put around the neck after the mine has fallen on you. And worst of all, Bulgaria. Now, why Bulgaria? Fruit picking. And they do fruit picking by putting step ladders on vans and driving them between trees. That's almost Darwinian. You will find people come to you with published evidence, particularly ED people. ED people are obsessed with this, and they will wave a paper in front of you saying you should be using laryngoscope A, laryngoscope B, technique A, technique B. Always ask them what was their outcome measure, because there are hundreds out there, and that's part of the problem. If you put intubation and cervical spine injury into PubMed, you will discover over 3,000 papers, all of which look to different outcome measures. What we're most interested in is the risk of neurological deterioration. No papers talk about that. What do they talk about? Time to intubation. The worst endpoint of all time in any tracheal intubation studies. Who cares how long it takes? As an editor, it drives me up the wall when I see a new device and someone trying to suggest that device A is better than device B because you intubated the trachea 4 seconds quicker. I am not that busy that I need to save 4 seconds on every tracheal intubation. It is completely irrelevant, and more importantly, it is not patient-centered. Patients don't care about 4 seconds quicker intubation. They do not get home any quicker because you have shaved 4 seconds off the time. What else do these studies suffer from? Well, as I said, they're done by ED physicians. And this is the sort of view an ED physician needs in order to intubate. If not slightly better. When they wave the study at you, ask them. Say, fine, what glottic view did they aim to get? And almost always it's the best possible. So they'll be there, giving it a full beans, going to go, I can make that a bit better, I need to see everything. What they don't often say is they aim for minimal glottic exposure. And when I was taught to intubate trauma patients, I was told to aim for a grade 3 view at best and electively use a bougie. Very few of the studies actually assess minimal glottic exposure. Another endpoint they talk about is which device gives you the best view. Again, it doesn't matter. Particularly when one of the devices you're comparing to is video laryngoscopy. Video laryngoscopy is a view, but it's not a Cormack and Lehane view. They are different things. They are comparing chalk and cheese. And again, it doesn't matter what your view is, it's how easy or difficult it is to get the tube. We have all had very easy views and very tricky intubations. What's the endpoint that does matter, if you're going to look? It's this one. You want to know about space available for cord. We're interested in the amount of compression that occurs at the spine. And this is usually measured radiologically, and it's the gap between those areas. So this is C1, C2, and at this level, the space available is in there. Obviously, we have the bit of bone in the middle, which takes up a third, and the cord there takes up about a third of the total available space available for cord. They also need to be very clear about what level they're looking at. That's at the top of the cervical spine. If you go down to the bottom to C5 and C6, at that level, 75% of the space available for cord is actually filled with cord. So it's at the lower cervical spine where the cord's more likely to be impinged. So unless they've measured dural sac compression or space available for cord, we probably can't comment on those devices. I've got a BMSI student currently doing an analysis of this, looking at that. So far, he's identified 3,000 papers. We're trying to look down to see how many of these use these endpoints. We're not expecting it to be very many. If he ever manages to differentiate the library from the pub, we might finish this soon and be able to give you a definitive answer in due course. Spinal immobilization. So again, this is a great pseudo-axiom. This was created by a US Army colonel. And this is the line he wrote. This is how we created it. We are all familiar with hearsay reports of making things worse by taking people out of cars. Hearsay. Not RCT evidence, not even retrospective cohort analysis. A man told me that someone got worse when we took him out of the car. That's how spinal immobilization was born. That's how they used to do it. But that backboard looks remarkably similar to what we still continue to use now. And that's part of the problem, is once you introduce these things, they're very hard to get rid of. Similarly, cervical collars. This is a good collar. This is achieving a lot in that it's keeping the bright light out of his eyes and he can get some sleep. So I think this is a properly applied collar that will have immediate patient benefits. Most of the other collars don't. Again, this appeared in the literature, and there's very little evidence supporting the routine use of cervical spine immobilization, and yet it is associated with numerous complications. So since we started removing collars on the basis of normal CT scans in ITU, the neurosurgeons got very anxious, saying we would miss potential injuries, and we will. We estimate that we will miss about 1 injury in every 5,000 cases. So about once every 15 years, we may miss an injury. Within that similar timescale, we estimate that somewhere between 300 and 3,000 patients would have suffered a significant complication as a direct result of spinal immobilization. They also don't work. A big review by Schneider saw that actually putting a collar on transmits more force to the cord and reduces your space available for cord to a much greater degree than tracheal intubation. They're often malfitting. They often provide pivot points that increase force on areas of fracture. And there have been numerous case reports of elderly patients whose necks have been forced into collars who've actually had their necks broken by having a collar put on. A large meta-analysis of pre-hospital application of collars could find no evidence that it improves the rate of neurological injury prevention. What it was an independent predictor for death. This was a study that mainly looked at penetrating trauma, and it meant that patients were bleeding to death at the scene while someone put a collar on, rather than getting them where they needed to be so they could have definitive care. So in terms of collars, I would view them as something that it's nice to have, but if the paramedics don't put one in when they come to resus, I don't put one on, and I would certainly never let it interfere with any life-saving intervention, whether that's airway maintenance or transmission to surgery for bleeding control. Manual inline stabilization. This is something you must do, isn't it? This appeared in ACLS guidance in 1984. Again, just appeared, it's fine, don't worry, Rhinoceros. And this is the picture they use. She looks lovely. She's got her earrings in, she's got makeup on. She doesn't look like she's going to be that difficult to intubate. Okay, you can do manual inline stabilization on her. This is the reality. This is Johnny midlife crisis, who got on his motorbike and crashed it, who's grown his fat man's beard because he's fat and middle-aged and trying not to show that. And he's going to have manual inline stabilization and cricoid pressure. Manual inline stabilization doesn't stabilize the spine. What it does do is increase your chances of having a grade 3 intubation view from around 2% to 20%. So if he does have a cord injury, you're now making that cord more likely to be exposed to hypoxemia or prolonged pressure. Treat manual inline stabilization like you treat cricoid pressure in obstetrics. Fine, start with it on, but have an incredibly low threshold for saying, take it off. To further reassure you that all the other things we commonly do, such as cricoid pressure, jaw thrust, and bag valve mask ventilation, all cause more cervical spine movement than tracheal intubation. So if you do any of these things before you intubate the trachea, you've already caused more movement. So don't worry about it. Similarly, when you put your answers in for how you intubate the trachea, the good news is you are all right because they're all equivalent. They all cause similar amounts of cervical spine movement. So don't worry. Use the technique that's best in your hands because that will be the best one. And that's what, if I come in That's what I want you to do to me. I don't care how you do it. I want you to use your A-game best technique. Have you ever tried to give somebody else's anaesthetic? Did it go well? Don't do it with intubation then. Don't feel you should change a good technique that you're very polished at because it's a different clinical situation. Okay, controversial bit, blood pressure. When the major trauma centres arrived, we also brought in damage control resuscitation, which is a good thing. We don't do prolonged surgery. Even orthopods now ask about lactates. Who would have thought that would happen? We have rapid transit to theatre. We focus on hemorrhagic control. We avoid hypothermia, hypercalcemia. We give balanced fluid resuscitation. These are all good things to do. But we also brought in permissive hypertension, which is now perceived as being a treatment. You can accept a systolic blood pressure that produces a radial pulse, about 70 millimeters of mercury. Why do we do that? If we look at the books, it's because they talk about the pop the clot phenomenon. The idea that if we raise the blood pressure, all those clots that are formed are going to be exploded off and the patient will bleed to death immediately. That came from a vascular surgeon who did a self-audit of 88 cases over 33 years. Big numbers, big impressive numbers. He compared his outcome with another surgeon who he didn't like, and his results were slightly better. And he believed in permissive hypertension. And therefore, it's permissive hypertension that gave the enhanced benefit. Didn't worry about things like matching, propensity matching, severity of illness. It's not important, it's this. That's where it came from. And we haven't been able to get rid of that ever since. Never mind pop the clot, what about drain the brain? That's what I worry about more. The leading cause of death in UK polytrauma patients is brain injury. 60% of deaths come from brain injury. Exsanguination is less than 10%. And the majority of those, this occurs before they ever reach hospital. Non-survivable vascular injuries. Now we've got good helicopters, they're often getting to hospital and now they're dying with us. But often these are people who cannot be salvaged. Even from the early 80s, work by Randy Chestnut has shown that a single episode of hypotension, a single episode of having a systolic blood pressure less than 90 millimeters of mercury will double your mortality with traumatic brain injury and decrease your chances of a good neurological outcome by 50%. More recent data has shown that a single episode of a CPP less than 50 similarly doubles your 14-day mortality. There is no point in surviving your hemorrhage if you have no brain left at the end of it, or if you're going to be left highly disabled as a result. When we talk about permissive hypertension, people don't worry about giving all the blood volumes. You're allowed to give a massive trauma pack, that's okay, but God forbid you should give some metaraminol. And yet that seems to be okay. So what should you do? We have to be sensible. Permissive hypertension is not a treatment, it is a very worrying clinical sign. We don't have permissive really bad hypoxemia that we just go, it's okay. You go, I need to do something about that. It's exactly the same. Once you've put in your trauma pack, once you've protected that clot as much as you can with your FFP, your cryo, your antifibrinolytic, then you've done as much as you can. And my temptation then would be to push the blood pressure up to perfuse the brain then afterwards. You need to have a brain to survive. Most of the data from permissive hypertension comes from animal studies, and not even this rat can believe that that is the right thing to do. There was a big review in the BJA that was highly critical of animal studies. They said many were methodological poor, inadequate power calculations, inadequate blinding, very poor endpoint measures, and most showed very poor concordance with human studies. If we think about rats and permissive hypertension, if you cut more than 50% of this rat's tail off, he does worse with fluid. Less than 50%, he does better with fluid. I don't think that's directly applicable to our population. I'll be very wary of taking animal data and directly applying it to our patient populations. For similar reasons, ketamine, which did have a bad name, still has a bad name in FRCA MCQs, is a good drug. It doesn't affect your ICP if you control the CO2. The only time it makes your ICP go up is because you hyperventilate after ketamine if you're spontaneously breathing, and then your ICP will rise. In the context of sedation and controlled ventilation, ketamine will lower your ICP. In terms of blood product transfusions, so red for red cells, yellow, platelets, cryo, FFP is now often green if you're born after 1997, there's no right answer. We have extrapolated a lot of the military data and moved towards lower transfusion ratios, 1 to 1 to 1, platelets, FFP to red cells. The proper study was published last few years ago that compared 1 to 1 to 1 to 1 to 1 to 2, and that showed no difference in outcome and mortality benefits. So there's a move towards those sorts of ratios, but the precise one hasn't been determined. What is important is cryo. Trauma-induced coagulopathy is a fibrinogen depletion thing. So if there's one thing you want to put into your patient quickly and early, it's the cryo. That's the most important agent to give. Just coming towards the end now, we need to talk about tranexamic acid. I'm sure you will give it widely for most of the traumas that came from CRASH 2, which looked at 20,000 patients, and the gram straight away, and then the infusion over 8 hours. That showed an absolute reduction in 28-day mortality of 1.5%. So number needed treated for about 60, which is very good. Interestingly, it may be doing more than clot stabilization, because when you actually look at the study, transfusion requirements in both groups were the same. It didn't decrease transfusion requirements. So there may be a second effect that we're unaware of tranexamic acid, potentially an anti-inflammatory effect. So it may have effects beyond simple stabilization of clot. But we've had CRASH 3. And I started talking about fake news, and here is a brilliant example to finish with. Okay, this is the infographic The Lancet published. Now, The Lancet, let's face it, doesn't have the best track record of publishing high-quality studies. If I'd published the Wakefield, I might be slightly more cautious. This is the worst infographic I've ever seen in my life. I don't like infographics at the best of times. Infographics very rarely report negative findings. They always emphasize the positives, even if they're secondary outcome measures. They want to find the positives, and they're often not very critical. They very rarely cite weaknesses. This is a great example. CRASH 3 looked at exactly the same as CRASH 2, the same gram and gram in patients without multiple injuries, but who had traumatic brain injury. It was a neutral study. Tranexamic acid showed no benefit on their primary outcome measure, which was 28-day mortality. It showed no benefit. Don't let that hold you back. Let's report the subgroup analysis, the unplanned subgroup analysis. The unplanned subgroup analysis, that is underpowered as a headline result, that 1 in 5 patients could be saved. Let's not report all the other deficiencies. Why did they change the endpoint from all-cause mortality to head injury mortality? Why was the mortality rate so high in patients with minor head injuries? What's the mechanism of benefit of tranexamic acid in traumatic brain injury? You might imagine it would stop expansion of those clots. But that's true for some injuries, for example, an extradural or subdural. It's not going to be the case for traumatic subarachnoid hemorrhage. We also cannot assume that it's safe. They relied on clinical notes reporting thrombotic complications, and that was about 1.5% in each group. And yet we know in patients with traumatic brain injury, it's often as high as 20%. So that's a gross underestimate. So I don't think we should use tranexamic acid for traumatic brain injury, but this is an example of how pseudoaxioms start and how misinformation can be spread very rapidly, particularly in a 21st century social media heavy world. Okay, what have we run through today? I would encourage you to consider doing trauma fellowships and to take up consultant posts that involve trauma. It's difficult work, it's busy at times, you have to talk to an awful lot of surgeons, which is good and bad, but it's varied, exciting and incredibly rewarding. In terms of your day-to-day practice, please remember that hypotension is not a treatment, it's a bad sign, and you need a brain to survive. In terms of tracheal intubation, use the technique that's best in your hands and don't worry about the cervical spine. And whatever you do, please maintain a critical, cynical, analytical mind when you are told facts. There are rhinoceroses out there, you need to be able to spot them. And whatever you do as you become more senior, please don't create your own, because once they're running around your hospitals, they're incredibly difficult to kill. Thank you very much.